Take one. Mark?
Thanks so much for joining. I'm Dr. Mike Ruma, and I want to talk to you today about antenatal corticosteroids, an update on timing, controversy, and implementation in practice. I want to first tell you who I am and a little bit about myself. I grew up in Omaha, Nebraska. I was a Fighting Irish fan at the University of Notre Dame. Went to Creighton University School of Medicine, and then OB/GYN training also at Creighton. Did fellowship training at the University of North Carolina, Chapel Hill. Did a master's in health policy and administration there. And have been in private perinatal practice in New Mexico for the last 17 years. I want to tell you just a little bit about the scope of our practice. New Mexico is an interesting state. It's the 5th largest state in the United States, very rural, 23 tribal nations, and extreme distances, which is why you see this map here in front of you describing 5 physician offices and multiple satellite offices. We do tertiary care in one particular hospital in central New Mexico. We're going to get into our lecture today. I want to review fetal lung development, talk a bit about historical contributions, and then summarize a variety of clinical studies, talk about current recommendations, and as always in medicine, talk about some recent controversies. This particular medication, antenatal corticosteroids or ACS, is it the most effective therapy we have in perinatal medicine? It's undoubtedly helped save and improve the lives of a countless number of preterm infants. But even in its beginning, in its birth, it was controversial. And even today, it's still surrounded by uncertainty. Respiratory distress syndrome is the primary cause of early neonatal death and disability, and it affects a lot of preterm infants, 50% of 28-weekers, 33% of infants born under 32 weeks. And it affects, if you like, birth weights, about 40% of birth weights when babies are under 1,500 grams. Why does this happen? Respiratory distress syndrome is caused by a lack of surfactant, poor lung development, because as you'll remember, there are 5 stages of lung development, with the last stage of lung development occurring at the end of age 2, after the baby's actually born. These steroids, that medication that you administer to that pregnant person, they accelerate the development and release of surfactant by type 2 pneumocytes. That particular compound, surfactant, improves lung mechanics. It allows the alveoli to open and close with greater and improved compliance, and that helps oxygen exchange. But as you know, clinicians, physicians, trainees, nurses, learners, as we reduce our amounts of stress and cortisol levels go down, so do those levels of surfactant. The first human trial ever done to demonstrate the efficacy of betamethasone, this is the exact same medication that we all use today. 12 milligrams of betamethasone, done in New Zealand by a professor named Liggins. Liggins had been studying fetal sheep and identified that when preterm sheep were born, we had better outcomes if that pregnant sheep had actually had steroids prior to birth, a preterm birth. And he turned this into a human study the following year. He enrolled 282 mothers that were in preterm labor or were going to have a preterm birth for some particular diagnosis. He defined respiratory distress syndrome as clinical signs of grunting, and then that classic radiological pattern of granular fine glass appearance on lung fields. As you can see in this landmark trial by Liggins, published in 1972, respiratory distress syndrome was markedly lower when preterm infants were born between 2 and 7 days after administration of antenatal corticosteroids. 33% if they received placebo versus 3%. This is a 10-fold reduction in a very bad outcome for preterm infants. Liggins concluded that respiratory distress syndrome occurred less in treated infants than in controls. And he concluded that there was sufficient evidence that we could do further trials about this topic. You can see here that we really latched onto this, and scientists all over the world redid this particular study. Over 24 times we completed this study. And each and every one of these listed studies showed the same benefit as Ligon's original trial. So where are we 50 years later? This ACOG committee opinion, as you can see, there is black text, blue highlights, yellow highlights, red text. Why so many adjustments to this particular topic? This publication came out in 2017, was corrected, reaffirmed, an advisory administered, and then yet reaffirmed again. And as you hear today and learn from listening to me, this particular topic is going to be readjusted in the future likely as well. ACOG agrees with Ligon's original trial. Antenatal steroids administered prior to an anticipated preterm birth is one of the most important antenatal therapies available to improve newborn outcomes. There are a variety of time frames in which we offer pregnant individuals steroid courses. A single course of antenatal corticosteroids are recommended between 24 and 0 to 33 weeks and 6 days if an imminent preterm birth is expected within 7 days. A single course is also recommended for pregnant patients between 34 weeks to 36 and 6 if preterm birth is anticipated within 7 days. Periviable steroid administration also is recommended today when patients and families desire full intervention on behalf of 22 and 0 to 23 and 6 week preterm infants. What's so important about this within 7 days? We're going to talk about that particular topic, and we want to understand the importance of this medication and why timing is so critically important. Steroids improve so many neonatal outcomes. I've talked to you about its reductionability in respiratory distress. It reduces infections. It reduces intraventricular hemorrhage. And it also reduces necrotizing enterocolitis for babies. Profound benefits for the preterm infant. However, as we talked about the physiology and the stages of lung development, when we administer a course of steroids and time elapses from when the pregnant person receives those steroids to when her infant actually is born, if we exceed 7 days, the benefit of steroids goes down. As you can see in this slide, the longer we get away from this ever important medication, the higher the rate of complications for that preterm infant, illustrating the importance of why we must time steroids optimally. How are we doing? Are we doing well? This is a study from Canada. An author, Razaz, looked at a 14-year period of time. And what the authors identified is that 23% of the time, pregnant patients receive steroids optimally where a child was then born within 7 days. Half of them received steroids and delivered near term. In another study, in the British Journal of OBGYN, we actually identified that only 40% of patients receive optimal antenatal corticosteroid therapy. We're very good at giving nearly all patients that have any reason to potentially be exposed to antenatal corticosteroids. We gave 93% of patients that showed up for nearly any reason to an obstetric unit, they received antenatal corticosteroids. But only 40% of the time was that preterm infant born within 7 days. If you look carefully at this graph, you can see that asymptomatic pregnant patients were receiving steroids. Why are we giving pregnant individuals that have no symptoms a medication when we know they have no symptoms? This study has brought about numerous questions on this particular topic. As you can see from the 2 prior studies, we're not timing steroids correctly and optimally. And the Society for Maternal Fetal Medicine has identified this and it has felt that this is so important that they have issued a special statement as of 2022 for you and I to better understand how can we approach the timing of antenatal corticosteroids. SMFM agrees with ACOG that steroids are optimally effective when administered within 7 days prior to a preterm birth. And they also recognize that we are not timing steroids appropriately to this 7-day time frame. Only 20 to 40% of preterm infants actually are exposed to steroids within 7 days. SMFM acknowledges that this issue arose due to the perinatal care quality metric from the Joint Commission that actually encouraged hospital facilities to measure the rate of steroids anytime before a preterm birth. And we were highly effective at achieving this metric. Around the United States, we were so good at giving steroids to nearly every pregnant person that came to a labor and delivery unit, we reached a 97% achievement of that particular Joint Commission metric. Do you remember this particular metric? This Joint Commission metric incentivized clinicians, you and I, to administer antenatal corticosteroids liberally, too freely actually. We can acknowledge two different studies and a special statement by SMFM that we have a low rate of optimal timing for this very important medication. And we also know that there's some recent studies that demonstrate there actually may be some adverse perinatal outcomes. If we administer steroids and the 7-day time frame elapses, the time frame when the medication is actually beneficial, and the child actually doesn't deliver in that time frame, and they go much further into gestation, maybe even are born at term, but receive preterm steroids. There are studies that demonstrate a higher NICU admission, smaller for gestational age infants, and very concerningly, mental and neurocognitive developmental delay. If you were to do a literature search on antenatal corticosteroids and adverse perinatal outcomes, you'd identify numerous studies. Take a look at some of the titles. Neurodevelopmental disorders among term infants exposed to steroids. Associations between maternal steroid treatment and mental and behavioral disorders. Long-term childhood outcomes for babies born at term who were exposed to antenatal corticosteroids. This is the first study that really brought to light concerns about adverse perinatal outcomes and actually adverse effects on children that had been exposed in utero to antenatal steroids. The medication's there, we want it to help the preterm infant, but if we don't time it correctly, this particular study brought to light some significant concern. Not a small study, 15,000 patients included in this study, 45% born at term, 55% born preterm. Again, not timing steroid exposure correctly. This study was done in Finland. Europe has a unique mechanism of being able to link the maternal EMR, the electronic record, to the infant and child's electronic medical record. We're not able to do this well in the United States. And Finland demonstrated and looked at any childhood mental and behavioral outcome problem on that active problem list in their EMR from birth to 9 years of age. They identified in their entire study cohort that there was a higher risk of mental and behavioral disorders in children exposed to in utero steroids. And then interestingly, stratifying the data, the effect appears to be linked when preterm steroid exposure is given to a pregnant person and then the child is actually born at term. Not if preterm steroids are administered and then the child is born preterm. There was some criticism of this initial study. And ultimately, the authors took that criticism and said, we're going to do it in a better and improved fashion. We're going to make it longer. We're going to look from birth to actually age 12. And we're not going to just generically describe mental and behavioral disorders. We're actually going to tell you what the outcomes were. And they sought speech and language problems in children, scholastic skill issues, developmental pervasive disorders, hearing, vision, cerebral palsy, adverse neonatal and child outcomes. And they looked from birth until age 12. Interestingly, in this study, they showed the same effect. The overall cohort showed an elevated risk of developmental and neurosensory disorders. And again, when stratifying the data, if preterm steroids were administered and the infant was born at term, there was a higher complication rate versus preterm steroid exposure and a preterm born child. People often question literature that comes from other countries. Is it applicable to the United States? Well, here's data from Indiana, University of Indiana, a group by Dr. Haas. And they looked at patients that were coming to triage, labor and delivery for symptoms of preterm labor. And they wanted to see that if they received steroids and ultimately delivered at term, were there complications associated with that? The outcomes they looked for were transient tachypnea of the newborn, NICU admission, and small for gestational age. And this was not a small study. 5,330 pregnant women were included in this study, and a third of them received steroids around 32 weeks. But again, you'll see that most of the patients, 50+%, delivered at term. In this study, if a patient was administered antenatal steroids during a preterm labor evaluation in obstetric triage, and then those infants went on to deliver at term, there was a higher neonatal intensive care unit admission rate. This is the very outcome we're hoping to reduce. But when we're not optimally timing steroids, we give the steroids preterm, expose that preterm infant, and then we're incorrect and they actually deliver at term, they have a higher complication rate. And they actually are also smaller. We know that steroids can affect the size of babies from other studies done in the 90s about steroids, where we actually linked steroids, repetitive weekly administration of steroids, to microcephaly and smaller heads. So this is not an unfounded association. The authors from Indiana stated that while the benefits of betamethasone are profound to a preterm infant, there may be negative impacts. And they advise you, the clinician, and me, when you're thinking about administering steroids to a pregnant person, potentially for threatened preterm labor, we need to be judicious, cautious. Take a pause and think about the real potential that patient has for delivering preterm. We've talked about a number of gestational ages where antenatal corticosteroids are utilized. Dr. Cynthia Giamfi-Bannerman in the New England Journal of Medicine published a trial, the Antenatal Late Preterm Steroid Trial, ALPS. That study is the preeminent evidence as to why we as clinicians utilize steroids in the late preterm timeframe. Having done that study, Dr. Bannerman wanted to identify, were there any adverse childhood outcomes in that study subset of children? And so she did a follow-up study of ALPS, looking at whether or not there were any cognitive impairments in those children having administered a particular test called the DAS-2. Of 2,831 children from the original ALPS New England Journal of Medicine trial on antenatal late preterm steroids, Dr. Bannerman identified 949 children for the follow-up study. And importantly, there was no difference in neurodevelopmental outcomes for children that were exposed to in utero steroids, illustrating the point that we believe there is no effect neurodevelopmentally on children in the late preterm setting. And this study by Dr. Bannerman, the follow-up study of her important ALPS original trial, is today published in the Journal of American Medical Association in 2024, again demonstrating the lack of an effect of late preterm steroids being not associated with any adverse childhood neurodevelopmental outcome. SMFM recognizes that we can do better to optimize timing of antenatal corticosteroid administration today, using the tools that we have today. And they want you and I, clinicians, physicians, trainees, nurses, learners, to thoughtfully evaluate the actual risk of preterm birth within 7 days before we administer antenatal corticosteroids to patients whose actual risk may be very low. SMFM identifies two particular types of patients whose risk of preterm birth is low. Patients with an asymptomatic short cervix should not receive antenatal corticosteroids. And patients who present with preterm contractions and have a negative fetal fibronectin test result should not receive antenatal corticosteroids because those two groups have a very, very low risk of preterm birth within 7 days. They're asking you, facilities around the United States, to evaluate and study this particular topic. We need to not ignore timing. We need to look carefully at our timing. And SMFM wants and encourages your facility to develop pilot quality improvement projects to try to improve this rate of optimal timing of steroids. How can you improve? How can we improve throughout the United States? We've all been in a room like this, the obstetric triage room. Why do we want to focus on preterm labor? So many different diagnoses. Preterm labor is one of the most common reasons that a patient presents to an obstetric triage unit. We want to ask them a variety of questions when they arrive. Have you had a prior spontaneous preterm birth? What kind of symptoms are you having? We need to do an examination on them. We need to potentially do an ultrasound and a laboratory test called fetal fibronectin. What do you see being done in your facility today? Is it always done the same fashion? Is each pregnant patient that walks into your facility receiving the same evaluation and management? Are you using a protocol? Something, as an example, like this listed from the Mayo Clinic. We have a number of tools that we can use when evaluating a patient with symptoms of preterm labor. We can do a cervical examination. It's an important portion of a clinical physical examination. But as you can see here, if we're trying to optimally time steroids to within 7 days, when a patient is minimally dilated, which is common, the chances that patient actually delivers within a week is small. If she's 1 centimeter dilated, 16% of those patients deliver in a week. If she's 2 centimeters dilated, only a third of them deliver in 7 days. Fetal fibronectin as a laboratory test was initially studied by Peaceman in 1997. Fetal fibronectin is a glycoprotein. It's found at the maternal-fetal interface, right between the chorion and the amnion. Peaceman wanted to evaluate pregnant patients with symptoms of preterm labor between 24 weeks and 0 days to 34 and 6. A speculum examination was conducted to collect the fetal fibronectin, and patients had to be under 3 centimeters dilated. A positive fetal fibronectin was defined as greater than or equal to 50 nanograms per milliliter, and there were 763 patients in this original study. The takeaway of this particular study by Peaceman was that when fetal fibronectin test results are negative, the probability of delivery, preterm delivery, within 7 and 14 days is exceedingly low. Less than 1% of patients are going to deliver in 7 or 14 days after a negative fetal fibronectin test result. Peaceman concluded in his discussion that the greatest value for this particular test in preterm patients is in those who have symptoms with preterm labor is really its negative predictive value for predicting impending preterm birth. And he alluded to the fact that we may be able to have less intervention. Less intervention may be appropriate when those results are negative, something that SMFM is asking us to do today. When we combined different components in medicine, physical examination, history, laboratory testing, imaging, we often can improve our prediction. That's called positive predictive value. You can see that when you rely simply on uterine contraction activity, that's not going to help predict preterm birth well in 7 days. You can see that if the patient's dilated about 1 centimeter, that's not also going to predict birth within 7 days well. Cervical shortening, slightly higher positive predictive value. Positive fetal fibronectin increases that together a little bit, but when you merge things together, you have a very short cervix and a positive fetal fibronectin test. Now we're upwards of about a 50% chance of preterm birth within 7 days. So what do you see happening? In your institution, are you actually trusting your lab results and the imaging and the workup that you do? This is a study from the Netherlands by Wilms. In the Netherlands, they had been evaluating patients with preterm labor symptoms only with transvaginal cervical length. And they identified that that was not working well for the country, and they implemented fibronectin testing. And what Wilm shows in this particular study is that we behave differently despite the evidence is showing us that we should do and actually follow a particular path. In women with a cervical length of under 30 millimeters, 1% of them deliver in 7 days, yet over 20% of them were given steroids. In patients that have a short cervix with a negative fetal fibronectin test result, 3% of those patients went on to deliver in a week, yet over 60% of those patients received steroids. These are two particular areas of opportunity where we can reduce inadvertent, unnecessary steroid exposure if you and I as clinicians, physicians, trainees, nurses, learners, when we evaluate patients with symptoms of preterm labor, we need to trust the test results and avoid inadvertent, unnecessary exposure to antenatal corticosteroids. We need to learn as clinicians, and my hope for you today is to take away from this lecture that we need to trust our tools. And there's substantive evidence about this topic. If you take a look at delivery within 7 days in this research study by Gomez, if we utilize all of our tools, we can improve optimal timing, and we can also avoid unnecessary exposure to antenatal corticosteroids. If you have a short cervix and a positive fibronectin, there is nearly a 45% chance that patient's going to deliver within 7 days. That is an excellent person to try to administer steroids to in a benefit for that preterm fetus. And if they're under 15 millimeters and have a positive fibronectin, now that rate is 75%. But if it's the opposite of that, if we have a normal cervix and a negative fibronectin test, we should not be administering steroids because that risk of delivery is so low under 7 days. Fetal fibronectin testing can also be useful when patients are admitted to the hospital and now have ceased having contraction activity. And Dr. Bannerman has demonstrated this in this particular article about asymptomatic patients that maybe made us so nervous because of their short cervix, they ultimately got admitted. In singletons and twins with cervical lengths under 10 millimeters, fetal fibronectin, when utilized and identified as negative, 0 of those patients, none of those patients actually delivered within 7 and 14 days. Fetal fibronectin laboratory testing can help guide discharge from the hospital as well. I've talked to you a lot today about laboratory testing, imaging, protocols, steroids, timing appropriately, the importance of avoiding adverse perinatal and childhood outcomes. Are we actually achieving this in the United States? This is a study from Dr. Sean Blackwell, former president of the Society for Maternal Fetal Medicine, looking at a large insurance database from 5 different states spread geographically across the United States. You can see that 20% of patients after their initial preterm labor evaluation return within 72 hours and deliver a preterm infant. And then you can see here that we're not evaluating these patients as I've just described how we should, with significant and sound evidence supporting that. 80% of pregnant patients that return to triage and deliver a preterm infant had no evidence of fetal fibronectin lab testing nor transvaginal ultrasound cervical length. If this was your sister, daughter, spouse, friend, what does that person, what does she deserve? They deserve equitable, equal evaluation with the confines of what literature and science show us today. How would I suggest that you go about evaluating patients? Pregnant patient comes to labor and delivery. She has symptoms of preterm labor, maybe back pain, maybe pressure. Preterm labor can be a sneaky particular diagnosis, but we want to take each and every one of these patients seriously. And we want to be equitable as well. We just saw from scientific study that we know not all pregnant patients receive the same care. We can do better. admit the patient to triage, evaluate the patient with standard laboratory testing, collect and send a fetal fibronectin test, and then work through the pathway. Most patients are 0, 1, or 2 centimeters when they present for preterm labor evaluation. Maybe in your institution, imaging is not readily available. Utilize and lean on the laboratory test fetal fibronectin. If that test is negative, the landmark study says that 99% of those patients are not going to deliver in 7 or 14 days. That patient can safely be counseled and discharged home without steroid administration. If the fetal fibronectin test is positive, now time to add imaging. Let's look at that cervical length. If it's profoundly short, time to act. That is your highest chance, the highest risk patient who's actually going to deliver possibly preterm based on science and deserves steroid administration and admission. ACOG wants us to make improvements in this particular area. The American College of Obstetricians and Gynecologists is calling all of us to action to implement protocols and checklists. In this particular document entitled Clinical Guidelines and Standardization of Practice to Improve Outcomes, ACOG is acknowledging that when physicians, midwives, nurses, trainees, all learners around and influencing the care of that particular patient, we can improve outcomes if we follow a standard path. How can we improve? What can you do better? Obviously, our literature is ever expanding, and we need to keep studying. We also need to be thoughtful in our evaluation and management of patients with symptoms of preterm labor. We need to use the tools that we have today. They will guide your management. And additionally, we need to implement and confidently follow protocols, trusting the test results to guide us on the proper and correct path. Bringing it all together, we can recognize that antenatal corticosteroids remains one of the most important interventions in perinatal medicine. The indications, the reasons we administer steroids will certainly continue to be refined and investigated. But we need more research and quality improvement efforts from you to help us improve this goal of optimal timing of antenatal corticosteroid administration for patients that are actually going to deliver preterm within 7 days. Because by doing so, we will work together to minimize exposure to pregnant patients that ultimately will give birth at term. I really appreciate the opportunity to talk to you today, and I look forward to next time. Thank you for listening.